Hello, everyone, and thank you for joining us this evening for week 6 of the RISE Institute and Rugby Research Injury Prevention Group 2026 Summer Lecture Series. My name is Kevin Serrano. I'm a rising sophomore biology and public health major attending Brandeis University from New York City. I'm a 2026 RISE intern, and I'm looking to go into physical therapy. Um, tonight's featured speaker is Dr. Todd May. He is a primary care and exercise physician at the Intermountain Healthcare. So, Dr. May, could you please share a little bit about your background and give us a brief introduction of what you'll be sharing today?
Sure. We're going to talk a little bit about concussions and how they relate to rugby, especially at the elite level. Going to show a few video clips from World Rugby's training modules that we all use to kind of learn from, and we'll talk through what the process is. We'll try to also get a handle on at a non-elite level. You want to make sure that you learn to recognize these, and once you do, you pull somebody out. There's no chance for a video review. My background is I'm primary care sports medicine. I went to Western University Health Sciences, although at the time when I was there, it was called the College of Osteopathic Medicine of the Pacific. I went to medical school and a Navy scholarship. And so after my residency, I started on my active duty service time as a family physician, and then I did my sports medicine training through the Navy and a program in San Diego called San Diego Sports and Family Medicine. Then started my time in the Navy doing primary care sports. I was in places like South Carolina where they train all the Marine recruits. I was at Camp Pendleton where I was became the program director for the Navy Sports Medicine Fellowship. I've spent time in both Iraq and Afghanistan. When I was in Afghanistan, I was there mainly taking care of concussions. These were blast concussions, not sports concussions, but we used the same model. Helped to do a little bit of research with MRIs and the way they look at things and how they use. It's called the DTI, diffusion tensor imaging. You can track water as it passes through the tracks in the brain, and we use those to kind of look and see what the concussions look like in both those that were the control group, which were non-concussed people, and then those that had the blast concussion. Either an IED would go off when they would be in the vehicle, or they were next to the IED and they had a concussion. And so I was in charge of kind of running that program. When I got back to Camp Pendleton, I also did the same thing, just filling in for a friend to cover that same system that we would use as they came back. And we're trying to deal with the more chronic effects of a concussion. So the headaches and things like that, trying to get them back on active duty or back up to speed, or help them get out of the military by being med-boarded out and being taken care of by the VA. I retired in 2017. I've been here at Intermountain ever since. When I got here, they were just starting up the Major League Rugby, and so I was a team physician for the Utah Warriors. Been doing that for the past 8 years. This year, funding fell through. We didn't have a team, but I've been able to be involved with USA Rugby. Most recently, over the weekend, the 4th, I was in Denver for a tournament. I actually got to function as the team physician for the Tongan national team, which was a blast. Those guys were a lot of fun. Watched the USA play Portugal. It was fun to watch everybody. My two teams that we won. It was fun to be there. I was in Kansas City for the Pacific Four tournament, one of those playoffs between Australia, New Zealand, Canada, and the U.S. So I have a fair bit of experience with concussions, and same thing with World Rugby's version of how they would like us to manage those concussions. And so that's going to be the focus of tonight. Anything else? That's a very long bio for me, I think.
Yeah, no, thank you for your introduction. Really interesting. When you're ready, feel free to share your screen.
Okay, let's see if I'm better with Teams and with. Let me see if maybe I need to move it over to the other side. Okay. All right. Can everybody see the screen? Let's go to. Okay. How's that?
Yes, that's perfect.
Okay. So let's talk about. I think we did the introduction and the bio. not sure everybody's experience with concussions and how they understand what happens. I explain it to patients as it's a power surge. So if you've been in your house and the power goes off, sometimes it flickers and comes back on. Sometimes there's a surge and the lights go completely out, and that's kind of what happens in the brain when the concussion hits or when it happens. The all of the neurotransmitters within the brain, they're all released from every synapse in your brain. There's also a flip-flop of the sodium and the potassium that are used to conduct the the impulse down along the spine, the process towards to the end. And then there's also some degree of calcium influx, which is what the excuse me, the arteries use to manage blood pressure in the brain. So all that stuff gets messed up, and you can kind of see a lot of things that happen in the brain. The most common is that you'll end up with what's called some retrograde amnesia. Many times they don't remember what happened for a few minutes to seconds before the injury. And then as they come to, they can remember. But because of all the stuff that's going on, they have a hard time laying down new memory. So that's where you get that forgetfulness. Most of the time that these concussions happen where you get kind of a whiplash motion. And so when that happens, the neck, the cervical spine gets irritated, the muscles go into spasms, and so you get some headaches from that. And then because of like the blood pressure, the calcium and the blood pressure changes, sonophobia, so sound bothers your ears, light bothers your eyes. You feel depressed, oftentimes sad. I had one athlete when I was in my fellowship. He was an American football player. He took a shot to the head and he came off the field just crying. And that was his symptom. He was just in tears, didn't know what was going on. And then within about 2 or 3 minutes, that all cleared. And then he was asking, well, why am I on the sidelines? What happened? So that those kind of things can happen as well. Sleep disturbances are very common in these kind of conditions or injuries as well. Oh, I guess I got to start a little too soon here. So this is the slide I guess it should have been. So I'm sorry about that. So oddly enough, you don't see any real imaging changes when you do an MRI or CT scan. Those do not show anything and are not really indicated or needed for to look at a concussion. Some people think that if you get a blow to the abdomen that's hard enough, the force gets transmitted up to the brain and can cause a concussion. I've seen that more in a blast concussion rather than a sports-related concussion. Generally, it's going to take about 14 days for your brain to recover. So that's the critical part for people, is being able to do that cognitive rest for those first 2 weeks to let the brain recover. For unknown reasons, female brains take a little longer to heal than male brains, especially in our adolescent population when they get a concussion. The problem is that we just don't know. We don't know what happens between the concussion and then the end result, which we think can be related to that chronic traumatic encephalitis. That's where people that have had multiple concussions, they end up with personality changes, they end up with bad depression, and many times they'll end up taking their own life. In the past, when I started my training, the typical idea was that if you get a concussion and it clears, you can go back in the same game. If it's your first concussion, if it's a second concussion, you got to wait a week to a month, and then the third concussion, you were out for the season. But many times these things are very much underreported for people, and you don't really recognize them. Plus the typical macho nature of a sport was that it was something to be ignored, and that you're fine participating even with the concussion. So you'll see varying kinds of symptoms, and some have more than others. But the goal is to early recognize these things and reduce them, to remove them from play, so that we can kind of let the brain recover. We do not know currently if that model is going to keep people from getting the chronic changes that a lot of the American football players have had. There's also been increasing reports about rugby players kind of having the same thing, because again, back in the day, they just played through their concussion and didn't really stop or anything, didn't give their brain a chance to recover. Okay, I guess I'm frozen. Okay, here we go. So this idea that there's an impact, and we're not sure if it's just the movement of the brain that causes it. Is there kind of a shearing of the neurons that's in the brain? We're not really sure what happens, but it disrupts mostly going to be the neurotransmitters and then the conduction of impulses along those. We talked about the other two, how long it recovers. So early on, headaches, dizziness, nausea, balance problems, light sensitivity, those are all physical signs. Brain or cognitive confusion, slow thinking, memory problems are really quite common. Emotion, you'll see irritability, you can see some anxiety, some depression, some mood changes. And then sleep, some do more, some do less. And then fatigue is a big one too. A lot of times they just feel exhausted all the time and they cannot get moving once they get done. So when you look at the comparison of concussions at the level of elite rugby union, which would be the national teams, super rugby in the Southern Hemisphere, Gallagher in England, United, and the rest of the world, that you're going to see about 0.4 concussions per 1,000 player match hours. School or something that's a little less, you see a bit more. And then community, which is usually a bunch of old guys that are trying to relive their rugby glory days, they get a lot more with those concussions. So when someone has an injury at the elite level, we do a couple of things. It's a 4-stage process that we want to figure out, did they have one and how do we best manage it? The first one is stage 1, that's in-game. So we're going to look at the video review, look for signs and symptoms, things that we would look for in that. And if it looks like it needs to be assessed, there's an HIA-1. This is really a modified SCAT-6 that World Rugby has put onto an app, and it takes the player through the whole SCAT-6, or sorry, modified version of it, which is compared to their baseline. And then based on that, the app will say either they pass or they fail. If they fail, you can override that. Having done that in the past, it seems like that's a bit of a mistake in my opinion now, but it'll show you that. And then if they're positive for this HI1, then they're removed from play. And then if the HI1 is negative, they can go back and they can play, but you have to have a stage 2, which is a more formal or a thorough HIA evaluation through that Scrum app. It's a more thorough SCAT-6. And then about 48 to 36 hours after, they have a third one, and then they go through stage 4, they'll get a fourth one as they return to play. Once they kind of get through stage 3, if they have a concussion, you're monitoring symptoms, and the athletic trainers are then following them through the process. There is a return to play protocol that they have to go through, where you have increasing levels of exertion and contact before they're actually cleared. For those that have had, I think it's 3 concussions in the past, there is a independent concussion consultant. They're in various parts of the world, experts that they look at everything from the video to the HIA forms to the return to play, have a conversation with the athlete to decide if it's going to be helpful for them, if it's okay for them to return, or should they go out, should they stay out. If you end up having, which and we'll talk about later, these category 1, then that is actually an automatic 11-day suspension. If you have some changes like in stage 1 or stage 2, but your stage 3 is normal, then those folk can be back playing by the following weekend. So it just depends on how they score, what they do. So these are some category 1 criteria that we look for. So confirmed loss of consciousness, a suspected loss of consciousness. Were they convulsing? Did they have this tonic posture where their arms are stuck out straight? They're kind of sitting like this. When they stand up or when they try to get back up to their feet, do they have like the balance? Are they moving to one side? Does it look like they're dazed? And that's the video part. On field is that someone's out there, usually your athletic trainer or a physio for the rest of the world. They're out there, they're talking to the patient or the athlete, and they want to figure out, are they orientated? Are they confused? What are their behavioral changes? Do they have nystagmus where the eyes are rapidly moving one direction or another? Or if they have any kind of concussion symptoms, those can all trigger this, pulling them off and evaluating them. So this is the harder one of the two. This is some criteria too. So do you suspect concussion? Do they have possible changes in behavior or confusion or movement? What was the impact? Does it look like they hit their head? Are they having what you think are these sub-threshold criteria 1, which we just talked about? Are they having some of those? The elite level, they have a mouth guard, and that mouth guard has a sensor in there that if they hit around 70 newtons of force, mostly a rotational force, that will trigger and it will show up as an alert on our Scrum app. That's an automatic pulling. That's an automatic HI1 screen. They can't. No one can say you can't have it. It has to be done. That's World Rugby's rules. And then that this is that level of impact, that 70 newtons. That's what World Rugby has decided is their level for that to be that trigger. So this is kind of an example of what the Scrum app looks like. You've got that person's name. This little the box right here that says HI3, that tells you what stage they're at. When you get started, you click on this new assessment and it runs you through the process of it. And it's everything's timed. There's instructions in there, so it's rather challenging to mess it up if you do it. But it just takes a little bit of practice to get used to the flow. We do a memory the word list. That's done early because you have to wait at least 5 minutes from when you finish that to do the delayed recall, and so otherwise the time frame is off. So when you get a concussion at an elite level or you're suspected, you have 12 minutes to do the assessment and have them back to the table where the officials are at so that they can clear them to get back into the game. They can't come in any sooner, but it's 12 minutes that you have to get through all that. And so they've designed this app to help you kind of manage your time and get it through appropriately. So what we're going to do now is I'm going to show you kind of some video reviews and see how this, we'll see, hopefully this gets us there. So this is kind of some of the training examples that they have. So we'll see if we can expand this up a little bit. There we go. Okay. So what you're going to see is a video clip of an injury. And then this is the process that we look for down here at the bottom. So player catches the ball so that you see the guy that's got the dark jersey on. He's the one. See how he hit and went down? So that's what we're looking at. So the play will go on and we're back in the back. We're looking at all these, the video review. And so then sometimes the ref will call it. Sometimes we have to call into the ref to say, hey, we need to stop. So he gets down here. And so the athletic trainer, the physio, is kind of talking to him, kind of trying to figure out what happened and what his symptoms are. So now we'll go back through the process. So you want to look and see, was there head impact? So see, he kind of contacts the guy's elbow. So what happens when he falls to the ground? He doesn't look like he protects himself very well. So he's collapsing down and then his arms are going to go out. So that's that tonic posturing. And then the delayed response is kind of what happens afterwards. And he's kind of on the ground. He tries to get up, but they're out there fast enough where they keep him on the ground to kind of, and then they'll go through this process of what it looked like. And then they decide, okay, yeah, he needs to come off and be evaluated. Okay, let's go. This one's a little bit interesting here. If we go to this one. So this is in a scrum, and you kind of hard to see. So this is some of the times you face this when you're looking at these. But then the scrum passes, and then they move on, but the player remains down. So he'll try to stand up, and they basically, say, no, you got to get back down to try to do an evaluation on him. Okay. So can you tell if there was head impact? You really can't because they're in the middle of a scrum, right? But you can see his knees going down, and then he kind of drops to the ground. So he doesn't really protect himself, and he lays motionless there. And then he remains down for quite some time afterwards. And then all of a sudden the lights come back on, and he goes to try to stand up, but someone's there to kind of like, hey, wait a minute, you got to be evaluated. So he gets up okay, but he's got to be taken out for an evaluation, a head injury. So, and that hand to the head, that's the signal that we use to suggest, to say that this person needs to come off for a head injury. So, let's go. We'll just do, how are we doing on time?
Don't worry about time. It's only been 30 minutes, I'm pretty sure.
Okay. So here's, we'll just do one more example to take a look at it and see what it looks like. Let's see, is that one going to work? There we go. Actually, I think I like this one better. So we'll start this one, and then we'll just do this last one. So here we go. So he's fallen down, and he takes a shoulder to the head. See how he kind of collapses and falls down? Doesn't really protect himself, and he stays on the ground. His teammate actually comes over the top to kind of protect him as they start to form a ruck that's sitting in there. But then they're trying to keep him from being injured any further. So he just kind of stays there and waits for the ref to kind of say, hey, this guy's out and he needs to be looked at. Now, this is one where if you watch him when he stands back up, he's got a little bit of like weirdness to when he walks, a little bit of ataxia as he kind of stands back up. So he's kind of woozy. He takes a couple of funky steps, and then he looks like he's okay. So those are the things that we end up looking for. Um, so if you're on the sidelines, you pull them out, and then they need to be seen or assessed medically, and then they'll have to go through a process of letting everything resolve, and then a similar return to play protocol that you would want them to do. So you'd start out with um, some light jogging, and then they can move up to faster speeds. Then they'll add in some back into their strength training, and then stage 6 is where they go back to contact. So you'd have to make sure all of their symptoms are resolved by the time they hit stage 6. When you go through these protocols, if you find that their symptoms are provoked at a stage, they have to take a day back. They take a day off, and then they go back a step. They do the one that doesn't cause symptoms, and then they move back up. The days of putting people in dark rooms and not letting them do anything, You want to avoid that. You want to let them do things up to their symptom threshold. So if they're let's say they're reading and they can read for 15 minutes and they start to get dizzy, then they can read for probably 14 minutes and avoid provoking the symptoms, but they're allowed to do that as well. And then the other thing we like to get them doing is walking. There are some good studies saying that walking helps the brain to recover. So early on, once the major symptoms are gone, probably the first 2 or 3 days, then people can start walking again, which can be helpful for them. If they're student athletes, the hard part is working with the school to help them get through their daily workload for classes, because they're going to have a hard time remembering things. So letting them sort of tape the lectures, having somebody read them a question, because they can hear it, but if they were to read it like on their own, they won't remember the question. So there are strategies to help them to get through their classwork as well. Let's see. So we kind of talked about this already. 11 days is the mandatory at the elite level, and they don't try to push that too quickly. So these are a couple of studies looking at how reliable this is. So it looks like it's pretty reliable. Inter-observer reliability is pretty good, especially when you get like the more obvious symptoms. And then the same thing with this criteria too. It does seem like it can be helpful. Although I was watching a rugby match between the Crusaders down in New Zealand. I forget who they were playing, but one of their players took a pretty hard hit to the face. And when they showed it on replay, I thought for sure they were going to pull the guy out. But he bounced back from it, didn't show any signs or symptoms, so they pulled him out. And so sometimes people will be a little bit more conservative with a hit like that to say, oh no, we should get him evaluated. Other times they'll just let it go, and it's kind of always interesting to kind of watch that. I was watching the Six Nations match between Ireland and Scotland, and Scotland's hooker got hit in the head pretty hard, and he showed all the signs, and I thought it was a criteria 1, but it turns out they allowed for an HI1 for him. So if there's a criteria 1 on the app, if you put that in, it doesn't let you go any further. That's an automatic, like, you're done. But as they talked, so the match day doctor and the team doctor were talking about it, and they said, well, he's had some other things that we think could explain his symptoms. Fortunately for the guy, he didn't pass the screening, so he was kept out of the match. But some of these nuanced things are a little bit challenging to figure out. And then the return to play, it does seem like they actually have better return to play and fewer symptoms if they have these. Plus, the idea that same day has become a much smaller number for them as we go through the this HI protocol that we use. This is the hard one for me to figure out. Like, I see some hard hits, and you wonder, they look okay on the video. There's nothing that's definitive. You wonder, are you pulling somebody out needlessly versus are you letting somebody play with a concussion, and so that you're trying to find that right balance between all of that. But yes, if they pass, they go back to the match that same. And so, coaches, parents, teammates, you should be having people look out for each other. You make them stop. Don't let them shake it off. You look for worsening symptoms, because sometimes these can lead to like a bleed in the brain. And so you want to keep an eye on the athlete as well to make sure it's not progressing. They're relatively rare, but they have occurred. And as the blood pools in the layers around the brain, it kind of causes compression of the brain itself, and then you can get bigger headache. They start getting, like, if they weren't nauseated before, then they get nauseated and they start vomiting. Those are all signs that you want to get somebody to an emergency room with proper imaging rapidly. And then make sure that they get support for their schoolwork as well as the return to sports. So This is the differences between the two, and this is why the elite team that they have a team doctor, they have physical therapists or athletic trainers. There's also the match day staff, which is usually a physician. There's somebody at the monitor marking the hits to kind of for review later. There's a formal program that we use, an app that World Rugby's developed, and then that return to play is managed because of the way it works and with the athletic trainers. Specialists can often be involved in our institution with our players as they went through their return to play and their recovery. We actually had them see a neuropsychologist who did some pretty sophisticated testing to kind of help us get rid of the background noise and rule out other things that this could be. We did have one athlete who had a concussion, and it took a long time for him to clear. He had some ADHD as well, and ultimately decided that it was time for him to not come back and play rugby again because his symptoms were persistent. He was having a hard time recovering. We also had another guy who was going up for a line out, and they took out his legs, and he had a pretty hard hit on his head, and it took him, I think it was about a month to kind of recover. And he ultimately, between looking at the neuropsych specialist and the testing, he ultimately decided that he wanted to kind of end his rugby career. He had been playing for a while. He was a player that came in with us from New Zealand. So on the community side, it's challenging because there's not really a dedicated medical staff or athletic trainer that's there. You don't have video review, and everything's based off of symptoms. And coaches and parents, especially with youth rugby, are the ones that are kind of leading the charge, and they often get referred to primary care, which they may not have the degree of training that somebody else has for these kind of conditions, and being able to work with the athlete to get them back, to get them recovered, and then to get them back into play. So these are kind of the takeaways from the what we talked about, and just making sure that you can recognize and remove at most people's level outside of the elite level. So you'll see these are the references if you guys want to look them up later. Okay. Let's see.
Thank you for that excellent presentation, Dr. May. It was really insightful on, lots of information on concussions and how
Yeah.
serious the situation can really be. All right, so that will conclude week 6 of the Rise in Student Rugby Research and Injury Prevention Group Summer Lecture Series. We would like to give a big thanks again to Dr. May for joining us today. Intriguing presentation, and everyone in the audience for their attendance. Thank you everyone for attending.
Thanks for those good questions too.